I'm Dr. Vincent Lam, one of the intensivists here at the University of Alberta Hospital. Thank you for joining us for our critical care ultrasound grand rounds for January 2022. Happy New Year to everybody. And the topic of today's talk will be POCUS as a core competency, which has actually been put into our EPAs as well as into our curriculum for critical care medicine at the Royal College level most recently in the last, I think, year or two. I definitely saw it on the EPAs for last year, and I'm not sure if they kind of, put it in 2019 or 2020, but somewhere along those lines. So I'm paging back and forth between two different devices, guys. I apologize, but it's to get the images to work better and not have the bandwidth always be doing video and audio and images at the same time. But the disclaimer I'll say right now is that I'm a researcher as well as a clinician. I have some disclosures in terms of POCUS type research. I have some grants from the University Hospital Foundation as well as the DCCM from the Royal ALEC and the Covenant groups as well to do some research in regards to POCUS stuff. But that's about it. I don't actually hold any, I'm not on any US companies for ultrasound. I don't sit on any boards, and I don't own any stocks or shares in US companies. However, I have a bias, and I'll say it right up front, that I believe that POCUS will make any clinician better and provide better clinical care when you actually provide it. Another bias that I have is that I believe that POCUS, despite being primarily in the past the armamentarium of radiologists and cardiologists, I believe that POCUS, because it's point of care and it's action orientated and it's at the bedside and it brings the clinicians back to the bedside, and more importantly, it provides point of care, so quick, determinable, diagnoses, that it should be democratized for all. And for those who are willing to train for it. So it's not just something that you just pick up and go to a weekend course and say that, I'm able to do this after 2 hours of lecturing and, 2 hours hands-on. It's still a skill that you need to acquire and develop and build a portfolio around. And it's not just something that you could just pick up and just say that you can do it. It requires constant practice, just like anything else in medicine. We practice all these things. And within Echo, we'll talk about it during this lecture, it's scalable. So for example, we'll talk about EKGs a little bit later, but almost all clinicians, even if psychiatrists is required, at least during their training, to be able to read an EKG. But that being said, we're not going to be nearly as good as EP physicians, right? But that's okay, as long as we can play in a world where, we diagnose the basics and things like that with Echo. Some of us will get to the advanced level to be on par or similar to cardiologists. That's okay, as long as we understand what our limits are and what our, how scalable this technology is and, in certain hands and things like that. As long as we know what our limitations are, we state up front what our limitations are, we can all play in the same sandbox. And as you guys know, we've actually trained emergency physicians, anesthesiologists, internal med, critical care, and actually other subspecialists as well. We're kind of delving into the neurocritical care realm. Endocrine doctors I know do their own FNAs of thyroid nodules based on teachings that they've had from POCUS. And urologists can have a look at, stones and ureteric obstructions and hydronephrosis and things like that. And vascular surgeons obviously are interested in looking at all the vessels that we can also sonographize. So again, lots of things that we can scale up, scale down based on this tool that's kind of like a Swiss Army knife or a jack of all trades knife, right? So next thing I'll just talk about is a shout out to Scott Millington. He wrote this editorial actually in the Critical Care Medicine Journal back in 2017. And at that time, the critical cell ultrasound article that he wrote was basically stating that POCUS, or critical care ultrasound, or basic cardiac ultrasound is what they put in this article, is a competency of critical care medicine. And it should be considered an important part of the clinician's armamentarium. And as such, it's actually been incorporated, starting through Scott and a lot of the people and players at the Royal College level, as a competency within critical care medicine. So where it's actually adjudicated, it's actually supervised, QA occurs where we give feedback to the learners, and it's actually assessed even at the Royal College level. And our most recent grads, Andrea Robinson and Leon Biker, have actually attested their critical care examination, not their fellowship ultrasound examination, the critical care based specialty actually tested them on ultrasound findings of lung and heart. So I just want to thank, before I even get started on the talk, many of the educators, mentors, and colleagues that have helped me along the way and helped, POCUS basically become what it is now within critical care. Most of the ideas that are from this talk are inspired by leaders, intensivists, some internists, and ED physicians in the field. You'll notice a whole bunch of people there that you might recognize, and also introduce people along the way in the Team USA group and then Team International groups that you may not recognize, but have been important players in getting us guidelines and position statements on being able to do this in this area. And one of the most important things that's actually helped us, and I'll introduce him right now, is Arthur Leibovitz. He's an intensivist and cardiologist and the past president of the NBE. And he first proctored the cardiology echo exams for ASC as well as NBE. And he's since become an exam committee member for the critical care ultrasonography examination. So despite the fact that, cardiologists have done echo for a long period of time, intensivists have also pushed this along the way, and we actually have the backing of other cardiologists to do so. So thanks to Warren Luxon, I'm not sure if he's on the line right now, but Lauren actually sent this in our POCUS chat. We have this critical care ultrasound WhatsApp group. And this was at the height of the pandemic, I might add. So kind of like 2021, early, I think March or April, this was an article that came out that stated point of care ultrasonography. And this came out in the New England Journal, right? So it was a review article by Diaz Gomez, Paul Mayo, who's the grandfather of POCUS Echo in the States. He trained a lot of our mentors like Rob Barnfield in Western, and Rob trained Brian and myself. And then Seth Koenig's also at the same school at Hofstra in New York State. And he's the head of the ACCP chest training program and is the chief of the ultrasound corner at Chest. And basically this particular article said that, as you can see here, point of care ultrasonography is defined as an acquisition, interpretation, and immediate clinical integration of ultrasonic imaging performed by the treating clinician at the bedside rather than by a radiologist or cardiologist, or as you guys know in our modern medical system, by techs, right? So it's actually the clinician at the bedside who's the MRP or part of the MRP's team that's doing it, not a kind of third-party ultrasonography team, right? And POCUS is an inclusive term, and it's meant to not be limited to any specialty, protocol, or organ system. And this concept that exists, and I'll go back to it again, POCUS does not belong to anybody. I want, and a lot of our POCUS colleagues want, democratization for all, as long as you're willing to learn the skills. You can't just pick it up and assume that you're good at it. You have to build on it. And this concept exists for other technologies as well. And it's scalable throughout those things. So I mentioned already before EKGs, GIM, ED, anesthesia. It's not just for cardio electrophysiologists. We all look at them. Chest x-rays are not just for radiologists either, right? Like a lot of subspecialties read them ahead of time to be able to, figure out if our line placement or ET2 placement is correct, right? So again, all these technologies, I'm not sure why echo got kind of put on this pedestal for a long period of time, but really in other areas of medicine, those technologies are actually, again, democratized for all. So next thing I'll go on to is just an outline. So we'll talk about musing about the medical system. I actually want some feedback from the group. You guys can vote maybe just on Zoom with the hand function, or if you guys want to turn on your cameras, feel free. But we're going to talk about musings about the medical system. The system itself may actually not always be patient-centered, but POCUS specifically is actually meant to be patient-centered. We'll talk about POCUS as a core competency, and we'll talk about the democratization and scalability, as I mentioned before. We'll talk about what kind of evidence there is out there in guidelines in terms of POCUS versus formal echo, how they're complementary to each other. They're not meant to be, replacements for one another. Risks associated with using and not using POCUS, collaborations between different specialties, and why we would use POCUS specifically in critical care, but why other subspecialties might use it as well, especially with this concept of whole body ultrasound. And the restrictions of POCUS have been, fraught with certain things, and I'll talk about those things a little bit later. And then we'll just get into some cases to end off the discussion with. So first thing I'll do is that, for those who want to participate with cameras, feel free to turn on your camera. If not, just, use the hand function in the chat. But medical systems using. So as you guys can see here on the left-hand side, this is an ACLS algorithm for cardiac arrest, 2015 update. And you'll notice in the bottom right-hand corner, there's a whole bunch of H's and T's that you guys have probably seen when you guys have run codes, or you guys at least studied this peripherally if you guys ever saw this. But a lot of those particular items, as you can see there, can actually be ruled out or ruled in by ultrasound, right? Thrombosis, tamponade, pneumothorax, hypovolemia, and assessing complications of VTVF. You can look for VSDs or mitral valve, prolapse or something like that if a papillary muscle rupture occurs. So how many of you guys have actually wished that you had an ultrasound, maybe prior to actually having ultrasound being as ubiquitous as it is now? How many of you guys have actually wished and hoped that you had ultrasound to help you rule out these H's and T's? Lynn's got her hand up, Adam, Alex. Okay, I can't see everybody's thing right now, so I apologize, but there's a lot of people that have their hands up, so that's really good. All right, next one is medical system using. So show of hands, how many of you guys have ordered an echo or radiology ultrasound and waited longer than? So you keep your hands up during this entire time. We'll go through all the different options. 1 day. So Nick's hand, Tim Chan, Lynn's up. 2 days. Long weekends, right? 3 days. Long weekends. Friday and Mondays. Greater than 5 days, probably less likely. I think hands will probably start going down by now. Or some hands are still up, maybe. Sometimes 7 days, could be. That would be probably more likely like a T, for example, right? Like if a T was scheduled only to be happening on Thursdays at your hospital, maybe that's why it takes a week to get those kind of reports up. Next up, have you ever ordered an echo or a radiology ultrasound and the patient has passed away prior to it being done? Hand up for Leon, Lynn, Tim, Nick. All right. Have you ever had to request an autopsy or the families requested you to do so because you had uncertainty about the patient's death or heart function at the time? So I'm not sure if Laz's hand is still up, but yeah. It's happened to me in my career for sure, even before I got into POCUS, where we weren't really sure. The patient died within 24 hours very quickly, and nobody really knew what was happening with the heart, despite the fact that the cardiac arrest was what brought them in. And this is more of a rhetorical question, so you guys don't have to answer this. But how many autopsies can actually reveal what the heart function was? The answer is probably 0%, right? Because the heart is in standstill at that time. You will only know heart function if you grabbed images beforehand before they died. So the pathologist can do their very best to tell you that they had CAD or their valve was this or their muscle was this, but it won't tell you what the heart function is unless you actually do an echo before they die. So a lot of times when we're filling out these death certificates, we actually don't really know unless we actually looked. And so again, another rhetorical question, I apologize ahead of time, but is the heart one of the most important organs in the body? I would say that it's probably yes, it is one of the most important organs. And I'm focusing on the heart specifically because of our previous history with echoes and stuff like that. And I would imagine that a lot of cardiologists would agree to this. So then why can I get some of these other tests faster? I can get a TSH, hemoglobin A1C, random cortisol. I can even get an IR embolization, even an MRI body maybe faster than sometimes I can get an echo. So that's why a lot of us in the critical care world, where there's some patients that can wait till Monday or Tuesday after a long weekend to get their echo, but there are some patients that can't. Middle of the night, Friday, 5 p.m., that they're not going to survive till Monday. But some of that information might still be crucial. Now, some people might argue that, well, they were going to die anyways. Who cares what their heart function was? But at least we know as clinicians that we did our due diligence. We looked, we figured out what their heart function was. And it actually might still inform some other things like goals of care discussions and family discussions that, yeah, the heart was really that bad. That's why they died, right? Or it was a contributing factor to their multi-organ failure, right? Why was their lactate 15? The heart contributed to that, right? All right. So system center versus non-system center. So patients, unfortunately, as I mentioned before, do not know to only get sick between the hours of 8 and 5, Monday to Friday. Evenings and weekends, most patients can probably wait for an echo, but there are some that can't. And unfortunately, that number probably is growing as more people present in the evenings, on weekends, and so on and so forth. And it's just it's non-zero number. And I would say that we are not doing our due diligence if we're not looking, or at least getting some information for that family or for that patient in terms of guiding things like epinephrine or advanced kind of cardiac interventions and things like that. So POCUS, I would argue, is actually more patient-centered. It's more timely. You can repeat it. It's immediate integration. The clinician at the bedside already knows the patient's history and can integrate the echo findings right then and there. Versus when you have a tech or an overreader system, like a system-based system, they are within the circle of care, but kind of just outside of it, right? And remember, they rely a lot on our clinical correlation, where we put in a vignette or something, in the order report. And overall, I would say that, they can still get it wrong, especially if we don't give them a good vignette, versus the person who's at the bedside conducting the actual study is also integrating the images. They can be the best person to kind of integrate all that information all into one report. POCUS, as mentioned before, as long as, so in my mind, and a lot of the POCUS people who use this kind of stuff, as long as our quality assurance and our quality of image acquisition and interpretation matches cardiology and radiology standards, then the biggest upside to us doing POCUS is actually the point of care part. Remember that we have things like golden hour of sepsis and getting antibiotics hung within the first hour, or trauma and EFAST exam and getting to the OR quickly. So how is it that it's okay in the past that we've been able to wait a day or 2 days or 3 days for an echo from now? Again, knowing that the heart is one of the most important organs, right? And again, I'm focusing on heart here, but we also ultrasound lungs, abdo, and some other things as well. But that's basically where we come from. So society supporting POCUS. We actually have published guidelines around this. Remember that we have the CCEX exam, just came out back in 2018, 2019. And they've had further iterations of this. Leon and Andrew are actually studying for this right now. The ASC and the AHA actually have in their own guidelines, and you'll notice that Vicky Noble and Arthur Leibovitz are head authors on this, describe the role of POCUS being performed by non-cardiologists in emergency situations. So these are actually in their own guidelines and in their own societies. They acknowledge that this should be done in emergency settings by non-cardiologists. The AMA, so not the Alberta one, but the American Medical Association has affirmed that ultrasound does not belong to any one particular subspecialty. And we should kind of get out of that mindset that, yeah, like a lot of the workhorse stuff and a lot of the major volume of studies that are done should be done by cardiologists and radiologists, right? That's definitely the case. But it doesn't mean that you don't have to wait basically to get another ultrasound. If you're concerned about this patient, you can get it for yourself if you can get the training for it, or you can get the skills to get it. So POCUS basically becoming more patient-centered required availability, ubiquitousness, timeliness, and repeatability. It also required training, and it required that more hands that were in the pot to be able to use it. So back to the democratization use. So ED, ICU, medicine, anesthesia, those are the typical subspecialties that we actually offer the critical care, the CRUS West course that Brian runs. And resuscitation, despite the fact that, echo belongs primarily to echocardiographers and cardiologists, resuscitation doesn't belong to anybody. So code blues can be run by different teams in different settings. In community hospitals, when I worked in Barrie, actually the intensivists were actually home call, and actually the emerge docs and the in-house IM docs were the ones that ran the codes. So again, like if I was to say that, oh, critical care should be, in addition to cardiology, the only ones to be able to do echo, that wouldn't be fair to certain patients, and it would be fair to other settings where other settings actually have different subspecialties running codes like this, right? So the tool was not always available in the past, but now it is more available for other certain subspecialties. All of us use different the different probes for different reasons. The linear probe, phased array probes, and curvilinear probes all are scalable. They all have different presets that we can use. And I think that we need to stop having turf wars over these tools, because multi-specialties are trained in using them. And now it's also within our education system as part of the Royal College that we should be trained in this fashion. So again, I think that it puts patients first. Whoever can do the scan in a timely fashion does it. And it's instant integration. So clinical correlation is not required. You're already clinically correlating as part of your care that you're providing. So, so people who are naysayers or downsayers to POCUS often talk about the risks of using POCUS, and this is very common. Everybody keeps saying that POCUS or ultrasound is operator dependent, right? But that's the same thing about anything in medicine, right? So Alec Weir is a colleague of ours, and Brett Nelson's also another colleague. He's in the States, and they kind of say they're sick of the operator dependent argument for POCUS. Everything takes practice, even in H&P, so history and physical, picking up the probe and getting to work and learning the skill. Rather than taking it away from people who are not good at it, you actually get them more supervision, more rigorous training, more adherence to guidelines, trainings, and standards. So Brett said, I agree. So unfortunately, within the POCUS world, we have a lot of sarcastic people, and so they say things like, oh, I stopped repairing laceration and interpreting EKGs once I actually found out they were operator dependent too. So remember, you can mitigate poor image acquisition and erroneous interpretation through further training. So we usually don't take away EKGs away from people if they're bad at doing it. We ask them to do more of it, right? We ask them to train further in it. And that's what helps them in the practice of medicine. So the other risks of using POCUS, and this is actually a very fair assessment. Oftentimes what ends up happening is it goes back to that sandbox where people are playing in the sandbox with, you know, basic POCUS versus advanced and so on and so forth. So the risk of using POCUS is that basic POCUS, and I'll define that a little bit later. Well, I'll define it now as well. Usually it's the 5 basic views: peristernal long axis, short axis, apical 4-chamber, IVC, and subcostal, where we're assessing basically 4 or 5 different things. So pericardial fusions, LV and RV function and size, IVC size, and, you know, collapsibility or responsive fluidness, and severe left-sided regurgitant lesions where you use color, right? All the other stuff requires spectral Doppler and more advanced stuff. But generally, this is the realm of POCUS, and this is what we teach at the CRS West course. It's modest objectives, but there's lots of literature out there saying that this can be reliably performed by non-cardiologists. Philippe Vignon is an international collaborator from France, and the French are actually some of the first users of POCUS, and actually a lot of the fathers and grandfathers of POCUS, basically outside of Paul Mayo in the US, are the biggest proponents of using POCUS. And the European societies, a lot of the intensivists actually use POCUS on a regular basis to actually assess, and they don't order formal echoes from cardiology. The yield of information that alters patient management is in the majority of cases. They actually found literature that it supports like 50% of changes in management actually occur if you do a POCUS. And there's proven influence on diagnostic accuracy, expedition of care in the ED and ICU, so you can triage better. I give an example. Laz actually scanned a patient who came in with rapid AFib, but got admitted to the hospital with the first admitting diagnosis of hepatitis NYD, whereby the patient actually had high liver enzymes, was admitted to general surgery, came in with a cardiac arrest with fast AFib, and Laz did a POCUS and actually found the patient had rheumatic heart failure with an EF of 20%. And the reason why the liver enzymes were up was actually because of congestive hepatopathy. It had nothing to do with a general surgery problem or obstruction or anything like that, right? So again, it can help you triage patients better if we do this. And it can also decrease consumption and resource uses of CTs, especially for things like lung ultrasound. If you can lung ultrasound them, find them have a fusion, then you save radiation, you save them having a trip to go to the donut of death, and you can do influence things at the bedside. So the risks of POCUS have been well outlined. What are the risks of not using POCUS? So actually, the risk of not using POCUS is the highest risk medical legally right now. And actually, these have actually been tried in courts regarding POCUS is at this time, the delay or lack of use rather than the misdiagnosis is actually what POCUS has actually been in the courts for. So denying patient access to a POCUS modality or delaying access to that POCUS or delaying or a misdiagnosis where that delay eventually increases mortality or morbidity has what has actually been shown to be litigated in courts. So it's not a surprise to learn that the malpractice cases related to POCUS have involved failures to use the tool promptly, not its errors in use. So when I say that, Lori Stoltz is a colleague from Arizona, Department of Emergency Medicine, and Massachusetts General Hospital and their division of law and global health and human rights and things like that. They actually did a deep dive into the literature in the legal world, and they actually found in a 5-year period from 2008 to 2012, 5 malpractice suits involving emergency physicians using ultrasound from the ACEP core emergency ultrasound applications were found in the Westlaw database. And all cases were related to the failure to perform an ultrasound study or failure to perform a study in a timely manner. And none of them actually involved failure to interpret or misdiagnose when use of point of care ultrasound. So again, we're more at risk of not using it and rather than the misinterpretation, that whole worry. And again, misinterpretation can be mitigated by training, right? So prior precedents in ultrasound disruptions, cardiac anesthesia actually is now doing their own intraop TEs. There was a time, maybe 20 years ago, where that wasn't the case, where cardiologists would actually come into the operating theater and TEs were done by them. There was a period of turbulence where the NB actually created their own perioperative transesophageal echo exam for the cardiac anesthetist. And it's similar to what critical care, ED, GIM, and anesthesia faces today with general POCUS with transthoracic and TE. But this evolved, right? So evolved to a consensus that arming the practitioners that were doing the actual case in the operating theater was necessary, and the skills to train them to safely perform TUs would actually improve the patient care and not pull cardiologists away from their other busy jobs and things like that. So it's actually become a core competency of critical care discipline within the Royal College, specifically in critical care, looking at POCUS, lung, and echo. Abdo and vascular is not there yet, but hopefully someday it will be. And then also ED physicians are actually tested at the Royal College level on their FAST exams for trauma. But we actually need a critical mass of skilled providers trained before potential improvements in patient care can actually occur. And that's why evidence doesn't really exist right now, but the hope is that it will someday. So as you guys can see here, this is the core competency. You guys have heard of EPAs before, competency by design. So as you can see right here in the key features, point of care ultrasound is actually in the advanced procedures of CCM guideline documentation. Right now, it's in a very infant form. As you can see here, it only requires that 10 observations of the achievement of heart and lung and volume status is done. Obviously, for Brian and I, and for people who run ultrasound programs, especially out east with Alberta Goffey and Scott Millington and Rob Barnfield, we feel that more is better, right? So generally, most of our trainees that come through the ultrasound block usually do about at least 25 lung as a bare minimum and 40 hearts. And that number changes between different jurisdictions and things like that. But again, this is a start to kind of having POCUS be within the critical care field. And remember, it's already on the exam tools. The PAC-Man study and a lot of the other studies within, the pulmonary artery catheter have said that, it's fallen out of favor in parts of the world and we don't interpret it very well anyways. And there's been a lot of harm that has actually come, even though they're, ends of one cases, but they do stick in people's minds. So I'll tell you guys a couple cases back in London. I wasn't involved, but one of my staff, he's a critical care physician as well as a anesthesiologist, and he does cardiac anesthesia at Western, Dan Bainbridge. So his first case, and this is why they don't use PA catheters routinely in cardiac surgery even at Western University, because of these two cases. So the first case was a routine MVR repair, so annuloplasty ring band in an elderly female diabetic with pre-existing pulmonary hypertension. That's why they put it in the first place, and they said that it was moderate pulmonary hypertension. The patient was extubated, but they still had the PA catheter in the next day, so post-op day 1. They were shooting routine numbers and they were wedging, and the RTs were actually doing this on behalf of the intensivists. So the intensivists weren't actually doing these numbers themselves. And unfortunately, in that patient, in a routine patient who had a very routine surgery, had the wedge occurred. It basically caused a PA rupture. The patient arrested and died and bled to death basically in their chest. So that was the first case. Second case, routine CABG ×4 and STEMI. No pre-existing pulmonary hypertension, but again, they put in PA catheters routinely in these cases for whatever reason, billing purposes, whatever. And unfortunately, during the PA catheter insertion, the patient VT arrested, did not even get their surgery, had to have open cardiac massage and all this stuff, and suffered anoxic brain injury, and the patient died, right? So again, PA catheters are falling out of favor. And the Western program and the UBC programs and some other programs don't even routinely use PA catheters in straightforward cases anymore. But because of that, we have this little bit of a void now. So where are we going to get our hemodynamic monitoring from? POCUS might be the best available option right now, especially if you do it transhoracically where it's not invasive like a TE. You can get good hemodynamic information. You can figure out what your RBSP is. You can figure out what pulmonary hypertension is doing. It answers more than just one question. It's multifunctional. So you can figure out, what's happening with the PA pressures, but you can also figure out what the cardiac output's doing. You can figure out what the valves are doing. You can figure out what the pericardium is doing, what the LV/RV function is. And that's 90% of what most POCUS and echo diagnosis is anyways. Like you don't there's a 90-10 rule where 10% of the extra stuff like diastolic dysfunction and all these other fancy things we learn in echo, it requires 90% of the effort, but 10% of the effort you can learn just from, and you can get 90% of the diagnoses. So again, RIP to the Pac-Man, but is echo maybe one of the solutions? Maybe. So the next thing I'll say is whole body ultrasound is becoming more of a thing now. So emerging use of whole body ultrasound cannot be separated from POCUS echo. Thoracic ultrasound is something we use on a routine basis. As Brian's probably using it right now in the unit to figure out if patients have empyema, if they have pneumonia, if you need a bronch versus a chest tube, and what their volume status is based on A lines, B lines, and so on and so forth, right? So again, abdomen is also used that. We use it in FAST exams. So there's an emerging body of literature that says that point of care ultrasound and adoption of POCUS makes this all the more intuitive to scan the entire body, but not to scan the heart and delay the best crucial information and deny, at worst, deny the comprehensive picture that it can emerge from a whole body ultrasound. It doesn't really make sense. So we have a vital heart program in the Edmonton area where people can get lysis even in the ambulance. So why not have POCUS as well as part of that? So restriction of POCUS, we're held to different standards. So POCUS critics will say, well, there's a relative lack of outcome data to actually use POCUS at the bedside. And that's very true. But what the authors of this, Scott Millington, the authors of this editorial actually said is that the greater use of bedside ultrasonography will eventually build more evidence or against or for, it could still be against, but more evidence for patient-centered outcome data around POCUS, right? So POCUS data is nascent, but it is emerging. More of it is coming along. And as we train up more people to use it, then we'll get a better idea. And it's the same thing with anything in medicine. Like when TAVIs first got started, they actually had a very high complication rate of, stroke and so on and so forth. But as TAVI technology came along and as people got better at using it, the outcomes became better as well, right? So I could imagine that as we train up more people, as long as we have high standards, again, there might be a transition period where maybe we find out the outcomes are poor, but over time, as we get better at this, we might actually find that outcomes are better. That's the hope anyways. Even if it doesn't show that, we might still be informing our patients and our families as to what's happening with their loved one a bit more quickly, as opposed to an autopsy and again. So remember, the vast majority of therapies within critical care and monitoring tools actually don't have a lot of clinical evidence, and they're actually like the Vigileo cardiac output monitors, even CVP art lines. There's not a lot of evidence to their use, but we use them anyways, right? So despite Pac-Man results, we still use PA catheters, and we rely on expert opinion and long track records despite harms and showing ability to interpret correctly. So ICU care and ICU procedures inherently have risks to them, right? We used to actually do blind techniques, but now we have ultrasound to actually improve our first pass cannulation, decrease our complication rates. And we actually teach this to our trainees as R2s within our unit, right? So not all CVLs are inserted by the ICU consultants. Not every chest tube is placed by a thoracic surgeon, right? But there's harmful delays in waiting for that person, like getting Ron Breezewell to do every single chest tube. Just like there is, if we don't train up enough people, the arrest that happens in the middle of the night that requires that chest tube, that requires that central line to be placed, won't be done because it takes a while for the consultant to come into the hospital. So that's why we train up our trainees, right? And we have to balance these risks versus benefits. And POCUS, I would say, falls into that category. We have to understand our strengths and limitations within it. But at the same time, we can democratize its use such that we know that trainees will get to the certain level, and people who want to do advanced stuff can challenge exams like Leon and Andrea are going to do. And consultants like myself or Brian or Rob Arnfeld or somebody else will eventually get to a level whereby we have a lot more skills, like even to use TE. But knowing all these strengths and limitations is really important. And it doesn't mean that somebody who has less skills than us cannot pick up the probe. People can still pick up the probe. They just have to understand what their limitations are. So what we want to do is essentially, we don't want people to stay in this bad side of the Dunning-Kruger, right? We want people to pick up the probe, get some skills with it, but not act so confidently that they know absolutely everything about it. Even to this day, I still am on this expert side of things, but my confidence, I still have things that I bump up to Aus Al-Herbish or Warren Luxon or some of our echocardiography colleagues, because I can't know absolutely everything within point-of-care ultrasound, right? And there's obviously things that they'll know or other experts will know better, but at least I know what my range is, what my skill set is. And, I'm never going to be the best at OB ultrasound, but I know a little bit about it to know that I'm not super confident about. I have some experience in it, but I can also look to other colleagues to help educate me and also get my scans better, right? So unfortunately, as mentioned before, nobody becomes an ultrasound expert overnight. You can't, Robin Scherbatsky is talking to Sherlock Holmes here, and a weekend course cannot teach you to be an ultrasound expert. In this, Billy Elliott is talking to Jack Sparrow, and unfortunately, not one ultrasound course will make you an expert in this. So we go back to competency-based training, competency by design. So in the early goings, when you attend an ultrasound course, there will be a lot of high anxiety, but also high retention because you're trying to learn this new skill, right? And it's often information overload, and you won't retain necessarily right after that particular course is done. And where, Brian and I and, the rest of the people who come through the ultrasound program, through the rotation for our 1-monthers, they often find that their knowledge formation and their high performance and their optimum performance and high retention occurs when they start building a portfolio, right? And so that's what we want to encourage everybody who wants to pick up ultrasound, is that don't just like do the ultrasound weekend course, also do the portfolio building, because you need to build up that 25 or 40 or whatever your cutoff is to become competent, at least within basic echocardiography and basic ultrasound. So we have the ACCP guidelines, as I mentioned before. Paul Mayo, Yannick Bellieu, who's actually at UDM in Montreal. Antoine Viron-Baron is one of the French intensivists. He's on this as well, and Philippe Vignon, you'll recognize before. And they actually outlined what basic and advanced cutoffs are for general critical care ultrasound and thoracic abdominal vascular, and especially echocardiography for basic and advanced. So back in 2017, Paul Mayo was actually at our Western ultrasound course, and he basically said, most people, especially if you're type A, especially if you're in the critical care world, nobody wants to be basic, right? Everybody wants to strive to be advanced, but that takes a process that requires work, right? Brett Nelson basically said, the secret to Paul Mayo's legendary status in critical care ultrasound, it actually might be double glasses. So Paul Mayo, when he rounds through the unit, actually wears double glasses. So Brett Nelson said, imagine what he can see that we cannot. So basic critical care echo, as I mentioned before, and it's been well outlined by these documents, Brian and I ascribe to them, is that we look at LV, RV function and size, we look at IVC, we look at pericardium, and we look at major regurgitant lesions on the left side, AI and MR. And the basic course, the CRS course, can actually teach you the basics. But we're actually here, well, at least a lot of us who are very interested in POCUS are here for the basic stuff, but as well for the advanced stuff. So remember, again, the 90-10 rule, to learn this extra 90% of stuff, to learn this extra advanced stuff, even though it's an extra 10% of extra diagnoses, it requires 90% of the work. So hemodynamics, devices, aorta, endocarditis, cardiac sources of embolism, procedural guidance. But we're here for you. Brian and I and all the other ultrasonographers in the program, we're here for you. We want you to learn these advanced techniques if you want to learn them. And the reason why that is that we believe in bringing guns to gunfights, right? So ICU is one of those areas where we have high fidelity, very sick patients, high acuity patients that deserve the best care possible, which also involves getting them the best investigations possible, right? So sometimes they can't wait till Monday to get that investigation from cardiology, and that's okay. And, you know, in our hands, we can do basic echo, but we can also do advanced echo, right? So Robert Artfield actually gave a talk to the Montreal Sono group in 2020, and he was talking about TE specifically here, but I'm going to kind of branch it back out to regular POCUS as well, bringing guns to gunfights. So TE is a POCUS tool, but I'm going to talk about just kind of everything else within POCUS as well. So it's as much as a mentality of an appropriate escalation to POCUS. In cardiac arrest, gravity of the disease, high fidelity, high stakes, why not get images for your patient? In this case, sometimes you can even use TE to get the best images to make tough decisions on patients that might not even have any other means to go down to CT or get to the echo lab and things like that for them to get timely care, basically. So it increases bedside confidence in diagnosis, it increases timeliness of answers. It moves the needle to actual intervention. So we learned in medical school that you know, an AS murmur is a crescendo decrescendo murmur on the right upper sternal border, second intercostal space, right? With a brachioradial delay, pulsus parvis retardus. Classic stuff, right? But you're never going to convince a cardiac surgeon to actually operate based on your physical findings, right? But we have used POCUS in the middle of the night on weekends in various centers, tertiary care centers, even quaternary care centers, even to actually push that needle to actually get intervention that's required, right? You know, endocarditis in the middle of the night, massive MR, the patient's not going to survive, they're on 3 pressors, so on and so forth. So that's actually happened in various jurisdictions. So I'll give an example of this. So hopefully this is our first clip that's actually going to try to play. Hopefully it's playing. But basically, this is a 50-year-old guy, type A dissection. He came from the periphery. Apologize if the video is going to keep cutting in and out. But he basically had an ascending aortic aneurysm with a dissection, and he was more short of breath and so on and so forth. So he's transferred from Sarnia Hospital in Ontario to Western in London, right? And the CV resident who was with me at the time basically said, oh, this guy actually has a classic Austin Flint murmur, and a muffled heart sound. But his surgeon wasn't convinced. So they actually asked me as the POCUS guy who was on, because again, it was a weekend, they couldn't get the echocardiographer tech to come into the hospital. Do I have to do an ascending aortic repair, or do I also have to do a Bentall? Do I have to also replace the valve or fix the valve, right? So having a look at this echo, you can see here is massive AI. This is from that patient, and I don't have the timestamp here. But basically, the patient had torrential AI. So the surgeon at 5 a.m., instead of waiting for the aortic surgeon to come in at 7 a.m., actually scrubbed in at 5 a.m., put the patient on pump. We still got the aortic surgeon to come in, and instead of doing a consent just for aortic aneurysm repair, they actually did a Bentall as well. So they actually included the valve and they fixed the valve and so on and so forth. So again, and also the patient actually, by the time they opened the pericardium, they actually had pericardial tamponade. So if that patient had gone at 7 a.m., which they planned to in the middle of the night, instead of at 5 a.m., the patient might have been dead. They might have arrested, they might not have survived this. And this patient actually ended up having a good outcome from their type A dissection. So again, this is TE, so it's a little bit different, but kind of similar. So again, we can employ this, and this is actually employed at University Hospital in our ICUs. And we've actually found endocarditis and rip-roaring AI, to which we've called, other services like CV surgery to actually come and look at this patient. This patient ultimately went on to palliative care, so didn't actually survive because they also had a stroke. That was why they were in hospital. But basically, we can diagnose these things on our own. So TE in the context of is just a tool, but TE in itself, and this is a wider talk for a wider thing, but we can actually still do basic things with this. So this is primarily just looking at AI, remember basic stuff. LV, RV, IVC, pericardium, and major valvular regurgitation, right? So again, this is not anything fancy with spectral Doppler, but we're diagnosing severe AI secondary to endocarditis from strep pneumo in this particular patient. So again, point of care ultrasound can diagnose just the basics, 90% of your diagnoses, and that extra 10% requires 90% more effort, but it's something that we like to do. So bringing guns to gunfights is really important in point of care ultrasound, and it's important to bring to the ICU specifically, and that mentality. It's similar to the other things that we have within medicine, right? Like, so the glide scope, right? So imagine an anesthesiologist telling you that, oh, you're not allowed to use the glide scope. Only I can use the glide scope because I'm the one trained in it, or I'm the expert in this thing, right? But the point of the tool, the point of the glide scope is to put the tube into the hole, right? It's supposed to intubate and capture the airway. So it's a disservice to patients to actually limit a glide scope to only anesthesiologists, right? So emerge docs use it. We use it in critical care. On the code teams and the periphery that I've seen in Barrie, the internal medicine doctors use it, right? There's lots of different people that can use a glide scope. So limiting technologies to certain subspecialties does not make sense. It is not supported by the Royal College or by most societies in general. Similar things, EKGs, as I mentioned before, it's scalable technology, right? So EKGs do not belong to cardiology. 12 leads and 15 leads can be ordered by anybody. Glide scopes do not belong to anesthesia. However, we still have deference to those subspecialties for the expertise that they have, right? So EP cardiologists can see way more in a 12 lead than I ever can, right? And they're better than most general physicians. But we can still diagnose things like STEMIs and heart block and things like that. And we can at least be good enough to do those things, but know our limitations. Same thing with bronchs. I will never do an EBUS, and I will never do an FNA of the subcarinal lymph node or transbronchial biopsies, but I can do basic pulmonary tombulating. I can, help out my colleagues who do surgery to be able to do a tracheostomy at the bedside. Some BALs, biopsies, and things like that I might still be able to do. But again, I have deference for the respirologists that can do more stuff, right? So the final thing I just wanted to end off on is that there's maybe some people who are still a little reticent to actually pick up the probe and do things. The final thing I would say in regards to point of care ultrasound as a critical care competency is, again, you will help patients if you start doing this. So I'm going to do some base case discussions. So first thing is that in this particular example, why use POCUS might be the only thing that you can do. So this is in the middle of a cardiac arrest, as you guys can see. The patient here is getting lots of fluids or lots of injections of other stuff because we can't even see the RV here. Remember, this is a T. This was done in London. And this patient here, unfortunately, has a big honking thrombus within their left atrium. The reason why this patient arrested, though, was found down overdose in the downtown area, and the thought was secondary to opiates. So they were given, basically, the cocktail of Narcan and so on and so forth. You know, in this high fidelity situation, sometimes there was no other choice. Unfortunately, the team was working on thumping and thumping on the chest. The Lucas machine was actually going by this time, so they couldn't actually, you know, get even a subcostal view. So sometimes T in the setting was high fidelity, and it can tell you things like predictors of poor outcomes. So the Gaspari trial, which is the Reason trial, showed cardiac standstills about 99.4% predictive of poor outcomes of cardiac arrest. And we're also doing research here with the PREDICT study as alongside the London group of 100% mortality with intracardiac thrombus formed at the same time as cardiac standstill. The other things too is that I talked to this before at some of the other grand round meetings, but a unilateral whiteout. What are you going to grab? Are you going to grab a chest tube, or are you going to grab a bronch, right? An ultrasound might have actually helped you instead of silently admitting to yourself that you've been fooled and you've grabbed the wrong tool beforehand. Within 2 minutes, or even less than that, you could probably figure out if it's an effusion or if it's a mucus plug or some other cancer or something like that, right? So again, dynamic air bronchograms, as you can see here, it's, yeah, there's a fusion here, but maybe I'll actually grab my bronch for this particular patient. Or in this case, right, it's more of an effusion for a unilateral whiteout, right? And this one is a very complex one. So instead of me grabbing a pigtail, I'm actually going to grab a surgical chest tube, and I'll probably put some TPA and DNase in there, right? So these are all things that you guys can do at the bedside as part of your critical care training to do so. And I'm speaking to the trainees in the audience, but also to the staff as well. So another case example. So this was a 40-year-old smoker admitted to the respirology ward for BiPAP and secondary acute exacerbation of CPD. And then fortunately a code blue gets called, right? And the code blue, as you guys can see, is ongoing. But this patient actually did not have a respiratory arrest secondary to their COPD. Their baseline bicarb isn't even that high. This was the reason why they arrested. So again, nobody would have known this. They had to look at the x-ray. The x-ray was completely clear. The heart didn't even really look that big. But this patient, who was a smoker, 40 years old, young, unfortunately had small cell lung cancer. So during the cardiac arrest, we were actually able to get her back, and we actually tapped this effusion alongside cardiology because she was back by then on 3 pressors. But we were able to tap that effusion. She got a pericardial window. She survived, surprisingly, despite having an intrahospital cardiac arrest. And she actually lived another 2 years, right? Because she got cisplatin and etoposide. She got some radiation for her big immunocytoma mass and things like that. And so, maybe not always in this outcome or in this kind of particular patient population, but the POCUS definitely changed management in that particular patient for that day, right? And if they just ran the code as if this was a respiratory arrest, the patient would have died. Advanced echo, so T here. So this is a patient, I can't remember the vignette around this, but basically, oh yeah, so 46 bilateral PEs, bilateral DVTs, was already on fragment and under GIM for a fall because of non-operative from ortho. Code blue was called, peri-arrest, no hypoxemia, low BP, and low LOC, blown pupils, intubated. And T was to rule out RV dilation because they thought the DVTs had become worse on the PE side of things, and they wanted to see whether or not they could thrombolize this patient, right? So in addition to finding that the fact that the heart sucks, they actually found an LV thrombus too, right? So this patient actually got eventually, so this patient didn't survive, had bilateral strokes, had CT chest that showed coronary thrombosis, renal infarcts, splenic infarcts, and a trope of 50. Again, this is not the high sensitivity. This is the trope I or T or whatever, the old school one. And the patient rearrested. And actually, they actually found out the patient had APLA later, right? So their cardiolipin and their lupus anticoagulant was positive. So just, didn't add much to that patient's overall outcome, but it was interesting that they also had an LV thrombus, and that actually probably explained the strokes that the patient had, right? So LV thrombus again that you guys can see here. So another case here I'll talk to you about. 89-year-old female presents to the ED. We get involved because she's intubated and she has tearing back pain. And she rested in the ED, ROSCA for 5 minutes, and she's actually awake and alert and orientated after this. So unfortunately, this T, as you can see here, this is the aortic valve here. Oh, shoot. Okay, first of all, this is the descending thoracic aorta. You can see this flap that's sitting here. There's flow in one flap, not flow in the other flap, even at low 20. And this is the aortic valve, mitral valve. This is the aortic flap dissection, right? So unfortunately, she had a type A aortic dissection flap. She's 89 years old. She was awake with a breathing tube in, and we've talked to her after we did this TE, and her creatinine, unfortunately, was 300, so she was never going to get a CT to diagnose this dissection. So we talked to her and said, hey, look, you have a dissection flap. Typically, the cardiac surgeons would come talk to you. Do you want to get operated on? She said, absolutely not. We palliated her in the ED department. So again, POCUS basically got the diagnosis and was able to change management in that particular patient, even if her outcome was ultimately death. So again, type B dissection here, we can have the look at the aorta. This is heavily calcified, but you can see the flap here. And then this one is a mural thrombus. And this particular patient's aorta is 9 centimeters, right? But this was all investigated by POCUS people, either in the emerge, IM, anesthesia, critical care, right? We can also do OB scans. So this is a LIUP, late intrauterine pregnancy. And you can see here the baby is coughing at the end of it. You can see fetal cardiac movement. And we can also look at, maybe second or third trimester babies as well. We can look at their fetal heart rate and stuff like that. So again, in the POCUS world, I don't know anything about crown rump length. I can't tell you if the baby's going to be normal or abnormal or what their trisomy 21 stuff is going to be. But I can tell you that I can measure their fetal heart rate. So I put an M mode across the heart. Again, we don't pulse the heart specifically in infants and neonates. Or fetuses, because we worry about the Alera principle, which is as low as reasonably allowed. So we don't want to shoot a whole bunch of energy down to the heart, specifically at one point, especially with pulse wave. So we use M mode, right? So M mode basically is just shooting normal ultrasound towards the baby, and we basically get a signal back. And we can actually measure these little bumps here. You can see is 150 beats per minute. So again, when you don't have a tokodynamometer, or you're worried if this patient's fetus is actually having D cells and things like that, we can actually figure this kind of stuff out. So it's kind of cool that we can do this. And again, it goes back to the whole Swiss Army knife mentality of POCUS, right? And so unfortunately, we actually had a patient who had fetal demise as well. As you can see here, this heart is not moving. We have the barcode sign over here. We can do TCD, so we're doing more of this right now. I think bed 2, Laz is online right now, but there's a patient with acute liver failure who they're worried about cerebral edema in. So Laz is going to be shooting some MCAs later on today, and we'll have a look at those to see whether or not the patient has, signs of cerebral circulatory arrest or high ICP, basically, right? And obviously in this one, so again, normal MCA should look like this, just like any other art line tracing. As soon as you get, diastolic flow reversal and things like that, you're kind of getting into the area of circulatory arrest. So if the flow here and flow here is exact in terms of its the amount of area under the curve, you can say that, well, the red cells are moving this much forward and this much backwards, same amount, never going back to the lungs to get reoxygenated. This is in keeping with cerebral circulatory arrest, right? So just to end off here, I don't have too many cases, basically. I just wanted to give you a snapshot of what we're doing. But basically, we want everybody within the POCUS world to eventually go to that course, get some basics, start your portfolio by going to, Brian and signing up for a course, or, sorry, not a course, but like a month. And then eventually, even after your month is done, all the trainees that have actually come through us, we also still want to see their growth. We want to see them use it in their regular practice, still document their ultrasounds, and we want to see them basically grow and be self-motivated rather than stagnant or fall off the curve, because skills can stagnate, as you guys know in medicine, right? So again, are we as good as echocardiographers at doing some of this stuff? Yeah, even in transesophageal echo, I led this paper basically back in London that showed we had a 88 to 99% diagnostic accuracy or congruence with what echocardiography, cardiology-led echocardiography showed. There's a whole bunch of training that's happening in Canada right now. So this is only a snapshot. That's not even all of them. But the Western program has one, Ottawa, the consortium is actually nationwide. Toronto has their POCUS groups. UBC has their POCUS groups, Saskatchewan, McMaster, Queens, McGill, Dalhousie, Montreal, and UDM in Montreal, right? And so, obviously we do, with Brian being the leader here. Courses that are available, so we have the CRS West course that'll come up again. I think, Brian, you can correct me, probably in August or September of this year. The CHEST course is a weekend course as well. The Critical Care Forum, which is our major, conference that we have every year in Toronto, they actually have a couple ultrasound days as well. The Montreal Sono group, that is a medical student-led initiative. So medical students in Montreal are actually getting trained in POCUS as well. And then obviously the European groups and the SCCM in the States is also big up on POCUS. So a lot of this is actually coming, and it's already in our guidelines and already in our training programs. So for any of you who are actually interested in actually taking this a bit further rather than just doing a month with Brian, is that we actually have certification now not necessarily through the Royal College, but we go through the NBE in the States, and then there's the CCEX exam. I've written it. Brian's actually applied. He also wrote an exam similar to it, and he also has basically is a diplomat for that. And then the Royal College itself, for the basic stuff, as I mentioned before, in our EPAs, it's already there. So the last thing I'll end on really quickly is that, remember, POCUS is kind of like a scalable technology. It's a Jack and Jill of all trades. It's okay for people to stick on the left-hand side of the screen where you do the basic stuff. You look at RV, IVC, LV, pericardium, and you look at valves, right? Like just basic regurgitation stuff, right? But you can also get to the point where you become an expert or even a leader in this field, where you use all the different armamentarium stuff. You can do the abdo stuff, you can do the neuro stuff, you can do the MSK stuff, you can do, in addition to the cardiac and lung and all the other stuff that the basics guys do. And even within cardiac, you can do even way more advanced stuff in addition to that. So I just wanted to thank the Hospital Foundation, the UHF, and University of Alberta, Royal Alex Foundation, and Covenant. So just some exciting news, guys. We have 3 TE probes, as well as some more machines coming along, both in the neuro ICU as well as the general systems ICU, in addition to all the stuff that Brian's already gotten from before. Andrea Robinson was successful in getting a TE probe and a new PX machine over at the Royal Alec. And then Dominic Carney, as well as Leon and the group at the Grey Nuns, was able to get a TE probe over at the Grey Nuns as well. So we only had the Ms. and hopefully the Sturgeon to come online as eventually later. So, you know, hopefully we'll be able to do a lot more kind of like basic as well as advanced POCUS in the city at all our ICUs. The most important thing to take away from this, guys, is that if you're going to do something like POCUS, do it right. Make sure that you're still getting training for all this stuff. Don't just pick up the probe and think you can do it after a weekend course. If you need advanced critical care skills, look at the guidelines that we have, do some of the fellowships that we have, do some of, challenge some of the exams and study for those exams. It's the same thing for like carotid ultrasound, that you have to look at the NASCET or the ESCT. If you're looking at TCD, which is something that I do, I had to look at the IAUM, which is the Institute of American Institute of Ultrasound and Medicine, right? So I couldn't just look at our own POCUS literature. I had to look at their guidelines to teach myself how to do TCD, right? So therefore, you know, always look at the highest standard that you're going to do this particular investigation with, and learn to their standard. And you can always bring it back down to, you know, critical care or emergency medicine or, you know, anesthesia if you so do so. So until they come up with a tricorder from Star Trek, I'm going to still use ultrasound. If they do come up with a tricorder, I will, you know, I might give up ultrasound. I will learn the more advanced technology, right? So I'm not married to ultrasound, but I am of that mindset as a physician. I need to adapt or die. So I will learn whatever it is that's required to take best care of my patients. And at this time, I think, you know, Brian and myself and a lot of the others feel that POCUS and ultrasound is definitely a tool that we can use to better take care of our patients.